Welcome to the Doctor Journal Club podcast, the show that goes under the hood of evidence-based integrative medicine. We review recent research articles, interview evidence-based medicine thought leaders, and discuss the challenges and opportunities of integrating evidence-based and integrative medicine. Continue your learning after the show at www.drjournalclub.com.
Please bear in mind that this is for educational and entertainment purposes only. Talk to your doctor before making any medical decisions, changes, etc. Everything we're talking about, that's to teach you guys stuff and have fun. We are not your doctors. Also, we would love to answer your specific questions. On drjournalclub.com, you can post questions and comments for specific videos, but go ahead and email us directly at josh@drjournalclub.com. That's josh@drjournalclub.com. Send us your listener questions and we will discuss it on our pod. Welcome, everybody. This is your host, Dr. Joshua Goldenberg and Dr. Adam Sadowski. And today we are joined by the amazing Dr. Riaz Qureshi, who is an assistant professor at Anschutz Medical Center in Denver. And he and I did a little bit of work together maybe about a year ago or so. And then I found this article that he wrote and posted all over Twitter, and I was like, oh man, this kind of changes everything. So I felt like this would be a good time for us to jump in and talk about it, as every other day I decide AI is going to destroy the world or save us all, and we're going to be 10x as productive, and I haven't decided yet. And so I'm very interested to get your take within evidence synthesis. So welcome. Good to see you.
Yeah, thank you for having me. Great to see you.
Awesome. Okay, so this article, which we're going to post in the show notes, everybody, is about here. Let me get the title right. Are Chat GPT and large language models, I guess, the answer to bringing us closer to systematic review automation? And as listeners know, I'm a major evidence synthesis nerd, and Adam tries his darndest to steer me to clinical relevance for our audience. But unfortunately, I think I bring us to methods too much. So I would love to get your thoughts, Riaz. I also heard your talk on Pico Portal webinar a little bit ago, maybe a month or so ago, about a similar topic. This is when the Chat GPT thing was just blowing up. And so what I'd love to chat about today is, and then Adam, I want to get your clinical twist on my question, but as a nerd, I want to know what is the next step in evidence synthesis with AI and machine learning? So I'm using it in different stages. We can talk about it. I'm beginning to play with it, loving it. There's zero guidance, which is very frustrating, but I'd love your thoughts on that. And then in particular, what does the future look like? Do we still need humans? At what level do we need humans, et cetera? And then obviously that translates to clinic. But Adam, your thoughts from a clinical perspective to throw out as well.
Let's answer your question first, and then I'll come up with some clinical questions along the way.
Okay, don't let this only go methods. Our audience will hate us. All right, Riaz, shoot, go ahead.
Yeah, methods aren't everyone's bag of tea, for sure. But it is interesting. We've come a long way in terms of AI and its uses in evidence synthesis already. I will preface that while I'm a methodologist and epidemiologist, I'm not an expert in AI in particular. So, there's things that I might say that hopefully are my correct interpretation. But
we'll understand you.
We'll understand.
If you're a computer science person, we probably wouldn't understand.
Exactly. So, there are already systems in place that have been using AI and machine learning technologies to help with evidence synthesis in various stages. When you have a systematic review, your goal, your overall objective is to find all of the relevant literature that exists for a particular question and then synthesize it, which includes extracting the data. It includes qualifying the data and assessing the quality and risk of bias of the studies, and then qualitatively looking at what does the evidence show you? What are the actual results? What do they mean in the context of the studies that you found? What do they mean in the broader context of what you know already on the literature? And then making your sort of recommendations based on that. And generally, systematic reviews don't try and make so much recommendations as well as just presenting the evidence. You generally try and, I think, leave recommendations for clinical practice or guidelines to guideline developers, which is a further step above systematic review, sort of the overview where you might look at all of the systematic reviews on a topic and use something like grading of evidence, recommendations, and that system then takes into play the body of evidence and assesses the certainty of it. So there's a lot of steps into a systematic review, and it's a very intensive process that is very resource intensive, takes a lot of time, takes a lot of money, takes a lot of individuals. So it's definitely a ripe area for automation and for AI to step in. Where we see it being used already is in sort of the decision tree AI systems, things that the machine can learn classification based on how people are screening. So, primarily, we see this being used in a lot of the systems out there. Covidence is well established, Pico Portal is newer. We have Rayan, we have Data Abstractor, we have Systematic Reviewer, their Epi Reviewer. There's all these systems, and most of them have now integrated some AI capacity in the screening, where the system looks at the titles and the abstracts and assesses those. And as the reviewers are screening, the system is learning which titles and abstracts are more likely to be included, are more likely to be excluded. And then the system will help essentially rearrange the remaining articles to push the ones that it thinks should be included first, so that you can screen much quicker. And I do some work with Pico Portal. We've looked at this on our own system and found that there are pretty big bounds and gains and improvement in speed and efficiency in screening when you compare it to the random chance that you would expect for screening if you just randomly selected what you're looking at, right?
Well, let me interrupt you there and ask you about
Yeah.
that, because so this is a really excellent overview of like where, because most listeners may not be familiar with systematic reviews or how automation has played a role just in the past few years. And yeah, so using it for screening. So, systematic reviewers are going to be screening thousands, sometimes tens of thousands of citations. And just in reality, we get brain fatigue, right? You're clicking through thousands of abstracts and titles, making calls, include, exclude, include, exclude, include, exclude. Oh, there's a squirrel out the window. Shoot, did I just include that by accident? Did I double click that? And literally that happens. And, it's kind of crazy because it's a low chance, but you might miss this important study. And so for that reason, you do it in duplicate. And there's all these, mechanisms we have in place to protect against that. And it takes a tremendous amount of time. I've seen estimates of 1,000 person hours to get a systematic review done. That seems right to me. I've seen estimates of $100,000 in costs to get it done. That also seems right to me, and at least a year. So it's a lot. It's a lot of work. And you're right. This takes up a big chunk of time. So I've played with the automation. So let me ask you this. So the theory is with this that as you go through and click, the machine magically, I don't understand it, learns your choices and starts pulling them to the front, like you said. And over time, what you see is I'm using my hand as if our listeners will be able to actually see this. But essentially, at first it's sort of like random 1 out of 100 will be includable. And then all of a sudden it's 2 out of 100, 4 out of 100, because the machine is pushing them forward. And at a certain point, you've gotten all of them, right? It's pulled all the relevant ones forward. And the theory, I guess, and this I want to ask you about too, is that the last part you can just go so much faster because you don't have to use your brain as much. You're just like, no. I don't know if that's true, because if it's 100% accurate, you shouldn't have to use your brain at all. You could just assume everything is excluded at that point. If it isn't 100% accurate, then you still need to use your brain to have a human check. And I don't know that saves any time. And so maybe just a quick aside, I don't know that it's saving that much time. The studies I've said have seen like maybe a couple hours, in an overall review. Maybe that's unfair. Maybe I've heard people saying, well, maybe we just have one human look at the other ones. I would love stopping criteria. Like if you don't see anything for 500 citations, you just call it quits. Anyway, what are your thoughts on that? Like if we're really double checking the machine, how useful is it really?
Yeah, and that is really the crux of where we go with it, because we know the technology is there. We know that it's shifting things, right? Um, in the projects that we've looked at in our own system, where we had full double assessment all the way through at title abstract and then at full text screening, and we tested that sort of with the machine as well, just using the machine for its own classification. Um, and then against the reviewers, what we were finding was that after approximately 40% of being screened, they were capturing sort of 80% of the records that they had finally included at the end. So, screening titles abstracts, you only screen 40% of your records, and you've captured by that point 80% of the ones that will finally be included. And then it only requires you to screen 50-60% of records before you've captured 95% of the includes. So there's actually two sides to it. One is that where do you stop if you stop? So if you are doing a scoping review where your purpose is not to capture every single piece of evidence that exists, but get the scope of what exists out there and the more general topics that exist, so you can sort of classify where the literature is and where it needs to go. That's a kind of situation where capturing 95% of the relevant articles is probably enough, and you could probably stop. For a systematic review, if the prediction is at 100%, then you could probably stop as well once the system believes you've captured 100%. In practicality, it's never going to be 100%. It's going to be quite good. From most of the projects we see, the negative predictive value, which is what you care about in that context, because the negative predictive value is going to tell you of those remaining records that are said to be negative, right, by the system, what percentage of those are actually negative, right? As you can apply that in the same clinical context, but this is for applied to screening and reviews. So the negative predictive value, 99.5%, 98%, it's very high. What happens though is that when you have a review of 50,000 records and it believes it's captured all of the records by the time you hit, so you've screened 20,000, so you've only screened 40%, but the system, 20,000 records is a lot to help it make decisions and help it screen. And so it thinks that it's captured everything, even if that negative predictive value is off by, point of a percent. So it's 99.5% accurate. You're still going to have potentially 400 or 500 included records remaining in the last 30,000. So you can stop screening. I think, in my opinion, it's better to probably switch to a single screener. But at that point, you're then cutting your resources in half, right? You still have somebody check what the machine has been saying, but you are cutting the amount of time and effort and money that goes into the remaining screening in half.
So
And
I,
then,
I I think that's rational, but here's the fear. I want to get in a good journal. I need to follow guidance and then cite that I'm following guidance. And I'm waiting for that reviewer too to be like, what do you mean you didn't do double screening? AmStar 2 criteria says you need to be doing double screening. You don't have guidance for this because AI is advancing too fast for guidance. What does Cochrane say about that? So I'm afraid to make those changes now when I'm going for a good journal because I'm afraid I'm going to get dinged on it in peer review. So that's like, but I agree with you. I mean, I think that's an easy way to cut it, and I think we need some guidance. But Let me just stop for a second because I could talk about this all day long, which is probably super nerdery. But Adam, any thoughts from a clinical perspective?
No, I think that there's some stuff there that you guys pointed out that I would agree with, where you kind of need to sort of check the work of the computer. I mean, we kind of see it already where we have like interaction checkers with meds, where you'll prescribe something and then a pop up will come up on all red, and you can either just like hit acknowledge and ignore it, or you can be like, oh shoot, I actually, yeah, no, a good thing it caught that. I have to adjust that, or oh shoot, I forgot that this needs to be adjusted for renal clearance if you have patients with compromised renal function. So I think that's one good example from a clinical standpoint. But I think another thing that would be really interesting is if there's a way for the electronic health record with all of the clicks that you do can sort of like statistically create what is the highest probability of this diagnosis being correct, right?
Is that a
If some
thing? Do we have anything like that out there now?
I don't think so, but I think it would be really interesting, and maybe Riaz might know of some stuff. But I still think that even with that, if it's saying there's 98% probability that this is cholelithiasis, you could still be like, I do think that there's a role for clinical gestalt. I do think that is something that does need to be factored. I do think it's a thing. You can't rely on
I
it
think you
100%
mean
of the
cognitive
time.
biases of the provider. Is that what you mean by clinical gestalt? Just kidding.
I think something that AI may not take into consideration too is, your knowledge of the patient, especially from a
Right.
primary care standpoint. It's one thing if it's an emergent situation or urgent care. Is this a pulmonary embolism or not? Is really ultimately what you're thinking. If someone's, let's say, coming in for shortness of breath or chest pain or something like that, and would I think that would be helpful, because then it's like, okay, do we actually need to get a CT of the lungs? Do we need to do all these other expensive testing? Whereas if you're in the primary care setting and you have an established patient that for 5, 10 more years or so, you can kind of use that background data, knowledge of the patient, knowledge of what's going on in their life to kind of help make that decision making that maybe AI is not necessarily taking into account, especially if it's only going based off of algorithms from what you're clicking as opposed to sort of the background HPI. So if
But
there
it
is
could
some,
it could mine. I mean, that's these language modules, or I don't know the right language, but
Mhm.
that's what ChatGPT is my understanding, that they can crunch the HPI and compare it to other HPIs with known diagnoses, right? And then in
Mhm.
theory make a call.
Well, I've never actually used Chat GPT, so I don't know, and I haven't really like looked into it to know exactly how it functions. But um, then it's going to be kind of challenging. Like, are you just going to say, "Hey, Chat GPT, my patient presents today with
Hmm. Yeah, I think
chest
doctors are
pain.
already
What do I
doing that.
do?"
Riaz,
Yeah,
what do you think
it's
about in clinic stuff? Are there tools out there now? Is it analogous to what we're talking about?
I don't know, because I'm not a clinician myself, so I don't know if there are tools out there that are doing that. But I can tell you certainly it is an area that is talked about as future development, right? Diving into the personalized medicine, because these AI systems at their core are essentially giant prediction models, right? And that's actually one of the reasons why, sort of two points. One of the reasons why I think the ChatGPT and those sort of large language models will not probably be used for things like diagnosis,
Hmm.
because the language models at least are built differently. They're not so much built to look through data. They're not built to find evidence for things. If you ask it a question, it tells you explicitly, if you ask it to search PubMed, I don't have access to that. I can't do that.
Hmm.
Um, and as a prediction model for language, what it's doing is, with its terabytes and terabytes of data that it's been built on, is when you ask it a question, it synthesizes what you've asked. It looks at the context of the words that you've asked it, and then looks through and builds a response based on all the things that it assumes are related to that and would fit in with that. It's actually a little bit problematic in research because it does that so well that even, say, when you ask it for references, it knows the structure of a reference, right? Authors, last names, initial, and then journal, and then title and year, and um, issue, and number of the publication, page range. And it will create references that are made up because it
Yeah.
knows the structure and it knows what should be fitting in to answer the prompt.
It'll even give you like a PubMed ID number and a DOI that's made
Things
up.
that
It's
don't
crazy.
exist, right?
Yeah.
So this is called hallucination in the
I
AI
love
field
that
because
term.
it's
I love
it's
that term.
coming up with things that fit but aren't really real. So there's a real danger with that in the clinical setting.
It's a huge danger. You can't trust it.
You can't trust it. But that being said, there are lots of ways where AI models, sort of more simple classification models, which are still prediction models, but just using thousands, millions of parameters, are used in clinical care. And you see it a lot sort of more in the imaging world and ophthalmology in an ophthalmology department. Ophthalmology is actually sort of one of the leaders in that because so much of the work that ophthalmologists do and opticians do is based on images of the cornea, of the retina, on eye images. And so when you can feed models um, millions of images of confirmed diagnoses, right, then the system can take those images and can get very good, very accurate at assessing what's likely present based on an image, things that humans might not be able to see, patterns they might not be able to recognize. And this it goes beyond actually just diagnoses. I think there's was even something done that showed after it had been fed all of these models, right, with just an image of a retina, it could also tell you if the patient was male or female
That's crazy. And they've
because
even
because it
wow.
recognizes little things in there with the classified data that we can't see, but patterns
Huh.
that it catches.
Is it
And
able to like report that stuff? Like if it's a novel finding, can it explain how it determined that, or it's just like no, you just trained me on this.
so that's one thing that I don't want to make an answer on because I'm not that up to date on how the AI systems are working. But from my understanding, most of them sort of, this terminology black box is used generally to refer to most AI systems because you can feed it an algorithm, but then the whole point of the machine learning, right, is that it takes on something and it develops almost on its own through reinforced feedback. And by the time you get to output, even the people who created the algorithm aren't necessarily sure all the time
Huh.
how it's doing what it's doing.
So creepy.
And I think,
Yeah.
Josh, before you get into that,
Yeah.
another clinical, I think, advantage would be if it could somehow take into consideration like the patient's insurance and the diagnosis, and if you're like, what is the most cost-effective treatment option
Oh,
based on
that's
the
cool.
formulary,
That's
that would be
cool.
cool.
Huh.
Because you could say like, oh, they have, they let's say it's an individual with obesity and type 2 diabetes, and you say, I want to go ahead and prescribe, a GLP-1 agonist. But I don't know which one is going to be accepted by the payer or whatnot, or what the costs are going to be to the patient. If it could like print out
Man,
like
that'd be nice.
from like least expensive to most expensive options
Yeah, like
and
you need
kind
to
of like
fail these three first, so
well, not necessarily give you like the printout of like the PA criteria, but just be like, tell you like, okay, this is how much it would cost. Like this is
huh.
covered, not covered, or like requires PA, QL, like quantity limits, stuff like that.
Huh. That'd be
Or
cool.
be like, based on, 2013 ADA guidelines and all this other evidence, it's actually preferred to go with this medication as opposed to that. And so it could kind of, you could be like, what is the best option? Or once you click the diagnosis and the computer can like, take into account all of the labs and whatnot, it could just like shoot out like, system recommends this, acknowledge or ignore that. I think that would be really cool and really helpful, especially if it is able to bring up like background evidence to support that.
Yeah, and
Cool.
I think that kind of application is definitely achievable and
Mm-hmm.
probably not too far off as the
Right.
systems develop faster and faster. I think that's there. The side of it that, and you asked this a little bit to circle back um, on what will we need people anymore? Definitely, because as good as the prediction models can get, the issue is that people are not just models, right? People require a lot more, and people have input into their own care. The evidence based medicine triangle, really, right? You have best practice, you have
Mm-hmm.
clinical judgment, best evidence, and then you have patient desires. What does the patient want? And the model can tell you maybe what the best evidence is showing, but that's not, the patient may not want any of that.
Oh my god, you just like closed that loop for me. We've been like skirting around this issue forever. The third leg of the stool. Holy moly. I didn't even think about that in terms of AI. So it's interesting, right? Guyot spent like his whole career developing methods, algorithms almost for best evidence.
Mhm.
Um, AI can do that easily eventually, right? Clinician experience, either it's cognitive biases or it's pattern recognition that AI is now learning. And the big question is, oh, do you really need a human to check, or does AI do it better than humans at some point? No, neither being perfect. And I think probably in 20 years it'll be better than humans. But that third piece, the part that no one in the EBM movement until like Montori has started really talking about, that's the piece, man. That's where humans are still needed. And we have, ironically, we haven't done any work on that from an EBM perspective.
Yeah, and it's something that even if you do replace, somehow you replace the doctors with a robot that can go through and pick all the best things, the robot's not going to have the human interaction of talking with somebody, talking them through the options, figuring out what's best for them. So you need to still have a doctor who's trained in that to be there for that.
All those soft, squishy skills. Turns out that's the only thing we're good for.
Well, I know that at least when I was using Epic a couple years ago, it did have like recommendations built in for anyone who
Uh-huh.
had any sort of like cardiovascular disease or at high risk for cardiovascular disease. It would say like, hey, we recommend statin, um, maybe it would say like aspirin,
Just based on lab values and demographics.
based on lab
Mhm.
values, based on like, diagnoses that were in the chart. So, but that it was really only for that. I didn't see it for other things. Of course, it has its like health maintenance options that you need to address, but it from a treatment specific standpoint, really, I think only from a cardiovascular disease standpoint that I remember that it would make or offer you
Mhm.
a recommendation to consider. But yeah, I agree with Riaz in the sense of that human interaction and talking patients through a clinical decision or a treatment option is something that AI is not going to be able to do. I mean, it can write out a response as to why you should or should not do
Mhm.
something. But if that connection's not there, and you don't have that relationship with patients, they're just going to ignore it, or they may just ignore it.
I think another thing too to that needs consideration, and there's more coming out about this as models are being developed as well, is that with those predictions, right, for diagnoses, you mentioned the clinicians being biased potentially, and maybe the computers can do a better sort of assessment without those biases. But truthfully, the models are often biased as well
Hmm.
because the data that they get is biased, right? So there are lots of cases out there where um, the machine in its prediction ignores one side of something because even though it's a possibility, it wasn't really in there in the data that it had been given, and sort of taking into consideration things like race, ethnicity, or socioeconomic status, a lot of factors that can influence the care people are maybe receiving, or the care they have access to, and then that influences the amount of data that is available on people with particular characteristics, and so they're just not represented in the data, and the system doesn't know necessarily how to handle those issues. So there's actually a great deal of caution, I think, that needs to go in, as well as the models are developed for these applications, and care that needs to go into taking that, ensuring the models themselves are not unintentionally, creating biased decisions.
That's interesting. So it's the humans are feeding it troves of data that it itself is biased because of our human biases, and then it learns those things. Because if those are the test
Right.
cases, then or the training cases, I guess is the language. Then that's what it's going to interesting.
Right. Or if you think of it as not even a simpler, not necessarily a human bias being fed in, but just the bias in the data, right? So if you are feeding it, say, just hypothetically, data from a biobank of millions of people who are more likely to maybe seek that kind. If say your biobank is something like 23andMe or one of these systems that genetics, there's a lot of information in genetics, and that's the kind of area that's probably really ripe for AI because there's millions of variables. Not everybody is going out and buying those $150 packages to get their genetics tested, right? It's probably going to be mostly affluent people. It's probably going to be people of a certain background. And that's going to be entirely what your data set comprises of, right? So if you then try and give it parameters from somebody who doesn't fit within that mold, it's going to make judgments based on what it knows, but those are probably going to be wrong because it hasn't seen somebody with that kind of setup before.
That totally makes sense to me. That totally makes sense. Huh. Very interesting. I know we're coming up on time. I want to ask you one last piece. This is absolutely fascinating, and I think we kind of touched on this a little bit, but I do want to ask about the next step and then the future step. So, like, for example, I think we talked about screening. That's an obvious fit for AI. Huge amount of human time. We're not very good at it. We fatigue easy. That's an easy fit. Some of the examples Adam talked about, even the retina examples you gave makes sense to me. I'm wondering about like the next step of systematic review. Like, you're looking at full text inclusion, you're looking at quality assessment, you're looking at grade criteria, all of which is very subjective. And I would and I've seen some papers on like quality assessment, for example, that show maybe some promise. But yeah, I'd love your thoughts on that next immediate step of, okay, what about full text analysis? What about quality assessment? What about grade?
Yeah.
And then where does that go kind of in the like the near future? I mean, that I guess that's the question. It's like, I think screening is the no duh thing, but how does it fit in with, is it just we're just too early, we need more time, or do you think it'll be actually learn how to do that as well?
Yeah, no, it's a great question. And I think it's coming up for integration in different areas. And it needs less work in some areas than in others. So for the systematic review, once you finish your screening, you have to do your data extraction. That part, I think, is not there yet, but it is closer and it's getting there. That's something where you could theoretically train the model to say, given these bits of information, I want to know, give me the number of people in each arm. And you give it enough papers where there's a table, table one, it can probably pull out the numbers that are relevant from the top headers of the table, right? Those kinds of things I can see it doing, if not automated, at least requiring only one person to check, right? Or to go through and verify the data that it's pulled. So reducing time. That's the biggest thing. Risk of bias assessment, quality assessment, there's a lot of judgment that has to go into that. The challenge there is that pretty much always requires two people, where there is some application already. Even I think a few years ago, Robot Reviewer is a system uh, that has implemented risk of bias assessment. And when they compared it with methodologists, while they didn't always agree on the judgment, which is the qualitative part, they were pretty impressed, I think, with the sections of text that were picked by the system to support decisions. So, looking for evidence of masking of the trial participants, it's pretty, again, that's something where you could train it, this is how masking is usually described in a paper. So it pulls out the relevant paragraph or the relevant couple sentences from the paper. So that's something where the evidence can probably be trained to pull, and then you just have to have one person make the judgment on the relevant evidence. I think the ultimate goal, right, is to have the system be able to help in the actual synthesis, to actually the summarization, here's the main point of each article, the results, what does that mean in the context of each other. And that's something that I don't think we're there in the next while. That's going to be where the large language models come into play, because they contextualize the information using deep learning algorithms and things that are more advanced than just classification. Those are that's the area where it would be great to have some help, because it can take a long time, but it's also at the most risk of getting it wrong and promoting the wrong pieces from the various studies, especially if you just blindly trust what the system is telling you.
Yeah, interesting. Fascinating. And just one last tidbit, and then I want to ask if Adam has any final questions. There's also, so I'm terrified of AI, like all listeners know that. That being said, to play devil's advocate, and I do think it's a devil, there's this assumption that humans would do a better job. And I think if you look at overviews of reviews, at umbrella reviews, you can have the same data set come to 15 different conclusions, consciously or unconscious bias, all sorts of things. And so, yes, it needs to be checked, and so do human
Yep.
evidence syntheses as well. So the comparison is not 100% perfection. The comparison is against the alternative, which is humans. And so I think that's kind of an interesting twist on that. This has been fascinating. Adam, any last minute questions you have that you want to raise?
Not last minute questions, but I agree with Riaz of having something that can help from a data synthesis standpoint to help really cut down on the time with that, and honestly human error of trying to transfer data and putting it into data sets and whatnot. If you accidentally put in a 6 instead of a 9 or something like that, and then you could just be like, hey, run a random effects model using technique from Dersimonian and Laird, and then just shoot something out. I think that would be super cool, and time can save up on time. I think from a clinical standpoint, what would be cool is like if you could take a photo of someone's like diabetic log, or their blood glucose logs, or their blood pressure readings, and to transfer it then into the electronic health record takes a ton of time. So if you could just take a photo of it, and then it could just spit out like, here's your average, here's your high, here's your low, that would be super cool and totally clinically relevant. And then be able to track that over time, I think would be super cool.
Yeah, that's neat.
Yeah, and that would be something I think could probably be pretty feasible as well, because that's mostly image recognition, which even like Google Lens is quite good at, telling writing from script, and it's just a matter of parsing out the individual characters and the letters, numbers that are there, and then calculating averages. So that kind of application, it just needs time for somebody to develop it, but it's not far off, I don't think.
And I've seen apps like that for diet diaries, where you take a picture of your plate and it tells you the quantity. It's always wrong. It's always wrong. Unless it's a straight up hard boiled egg, there's like zero chance it's going to get it right with quantities. So, but maybe it just needs more time and more training. But yeah, it's a neat idea to think about. Anyway, this was fascinating, and I know like your paper is on systematic reviews, and that was like the methods conversation was the most of it, but I think it's analogous to like everything society is trying to deal with right now with AI. So thanks for coming on. Thanks for writing that. Thanks for being in the forefront of this. And we really appreciate you. Thanks for the time.
Yeah. Thank you very much for having me.
If you enjoy this podcast, chances are that one of your colleagues and friends probably would as well. Please do us a favor and let them know about the podcast. And if you have a little bit of extra time, even just a few seconds, if you could rate us and review us on Apple Podcast or any other distributor, it would be greatly appreciated. It would mean a lot to us and help get the word out to other people that would really enjoy our content. Thank you. Hey, y'all, this is Josh. We talked about some really interesting stuff today. I think one of the things we're going to do that's relevant, there is a course we have on Dr. Journal Club called the EBM Boot Camp that's really meant for clinicians to sort of help them understand how to critically evaluate the literature, et cetera, et cetera. Some of the things that we've been talking about today. Go ahead and check out the show notes link. We're going to link to it directly. I think it might be of interest. Don't forget to follow us on social and interact with us on social media. At Dr. Journal Club, DR Journal Club on Twitter. We're on Facebook, we're on LinkedIn, et cetera, et cetera. So please reach out to us. We always love to talk to our fans and our listeners. If you have any specific questions you'd like to ask us about research, evidence, being a clinician, et cetera, don't hesitate to ask. And then, of course, if you have any topics that you'd like us to cover on the pod, please let us know as well.
Thank you for listening to the Dr. Journal Club podcast, the show that goes under the hood of evidence-based integrative medicine. We review recent research articles, interview evidence-based medicine thought leaders, and discuss the challenges and opportunities of integrating evidence-based and integrative medicine. Be sure to visit www.drjournalclub.com to learn more.